All right, everybody, we're going to go ahead and get started. Good evening and welcome. We're so excited to bring you another session in the Immune Deficiency Foundation's Decoding PI series. Tonight, we are joined by Dr. Michael Jordan, who will share a research update on granulomatous lymphocytic interstitial lung disease in CVID. My name is Emma Mertens, and I'm the Program Manager for Education here at the Immune Deficiency Foundation. On behalf of IDF, we thank you for tuning into this virtual event. Throughout this series, guest presenters will provide a deep dive into clinically advanced topics from the world of PI. If time permits, the session will be followed by an audience Q&A with our presenter. In offering these programs, we aim to engage and empower the PI community through education. During portions of tonight's talk, we will offer audience polls. When a question pops up on your screen, you may submit a response by clicking one of the presented options. Also, a reminder that closed captioning is available. This webinar is made possible by our wonderful sponsors. It is due to their partnership and contributions that we can provide programs like this for the PI community. Please join me in thanking today's sponsors. Before we get started, a brief disclaimer. Please remember that information shared during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. All right, we're going to kick things off by asking you to answer a quick question using the Zoom polling feature, so you should see that pop up on your screen now. We'll give it about 30 seconds or so for everyone to answer. And our opening question is, which best describes your understanding of how primary immunodeficiency relates to granulomatous lymphocytic interstitial lung disease? Seems like we have a good, varied level of knowledge and understanding in our audience tonight, so I know we're all excited to learn a little bit more, and we really appreciate you all being here, so thank you. All right, with that, I am so pleased to introduce our presenter for this evening. Dr. Michael Jordan is a renowned pediatric immunologist and hematologist at Cincinnati Children's, where he specializes in treating young patients with rare immune deficiencies. Welcome, Dr. Jordan, and thank you for joining us.
All right, thank you, Emma. I'm going to share my screen here. Well, thank you for this opportunity to speak with the IDF audience today, and I appreciate this opportunity to spread the word, and hopefully this will be useful to the listeners here. So just a brief overview. I'm going to discuss a little bit about the problem of GLILD and CVID. Of course, I'll explain what those acronyms are all standing for as well. A brief discussion of how GLILD is treated, and then a discussion of why abatacept, why the ABCVILD trial, and then an overview further of the trial. And so, just one disclosure: the trial is supported by a grant from the FDA, but it's also supported by Bristol Myers Squibb, who make abatacept they supply the drug for the trial. So what is GLILD and why is it a problem? Well, first, I think before I can explain that, I have to give a bit more background, a bit more context in terms of describing a few things about CVID. Now, this audience is probably very familiar and with many of the things I'll share, but I just want to make sure we're all on the same page. And so CVID is really, I think, best thought of as a group of disorders or a category of disorders with a variety of known and unknown genetic causes. The category of CVID is defined, at least in part, by having low immune globulins leading to recurrent or severe infections. Immune deficiency, the immune deficiency aspects of the disorder can often be effectively treated with immunoglobulin replacement. Of course, this is a rare disease. CVID is typically diagnosed in the second to the fourth decade of life, though there are sometimes diagnosed in childhood as well. And this is usually done after ruling out other causes of hypogammaglobulinemia. or other specific disorders that may not be categorized in this, placed into this category. But the important thing, really, for this evening's discussion is that CVID is not just an immune deficiency. About a third of patients also have inflammatory complications, and this includes a really wide variety of issues relating to the immune system. And this, in some patients, it can include specific autoimmunity, things like ITP or autoimmune hemolytic anemia. But in other patients, it also includes accumulation of immune cells in the lungs or the liver or the gut, oftentimes enlarged spleen. And it's these complications that are actually the major driver of medical difficulties for these patients. And they're unfortunately the major cause of premature mortality as well. And so here's a very recent report from just earlier this year from a German group, and they looked at their patients, a large cohort of patients with CVID, and the patients that had just infections only, that's CVD-IO. You can see the survival curve in orange, and the patients with these quote-unquote complications in blue. As you can see, there's quite a difference between the outcomes of these patients over the decades after their diagnosis. And in terms of the prevalence of complications in patients that in this cohort that were deceased, you can see there are a number of different things that occur, and there's the timeline on the right in terms of when these occur relative to passing away. And but of course, I just wanted to highlight ILD, which is short for interstitial lung disease, and which is really what we're talking about this evening as one of the major causes for concern. And in a prior older report, there's an analysis of conditions that are associated with increased risk of mortality and chronic lung disease, which includes things like ILD or GLILD, as well as other lung issues, is one of the major issues of concern there. In fact, it was the number one cause of death in this series of patients. Now, I've been talking about a little bit about GLILD already, but haven't really defined it properly. So, this abbreviation stands for granulomatous lymphocytic interstitial lung disease, or GLILD, and it's really a spectrum of interstitial lung diseases, as the name kind of implies, and it's seen in patients with CVID, and this is different from, let's say, bronchiectasis or scarring in the lungs. And by the interstitium, what people are referring to is actually the tissues of the lung itself, as opposed to the airway spaces. So, for instance, if somebody has pneumonia, then that's typically defined as infection or fluid in the airway space. This is actually not the airway space, but the actual within the tissue, or what's called the interstitium of the lung itself. And sometimes it crowds out the airway, but it's a different location. And as I've already indicated, it's really a spectrum. It's a spectrum in terms of what you see on CT scans, and I'll describe that more in just a second. It's also, there's a spectrum of what you see on biopsies. But in most patients, what you really see are really strong infiltrations of immune cells. And in other patients, you see more or less granuloma. And granuloma really refers to a particular sort of organized kind of inflammation that can be recognized under the microscope. It also includes cells, but it's a particular sort of organization of infiltrating immune cells. The pathogenesis of GLILD has been and remains unknown, but it is apparently non-infectious, though obviously infections are always a concern, but it really appears to occur in chronically in the absence of any known infection, and of course, by definition, it's not malignant. And if it's not effectively treated, it can cause progressive lung injury and ultimately decline in lung function. That is really what is important for quality of life and longevity. Now, GLILD, when looking at X-rays, it has a variety of different manifestations. Some of the most classic manifestations, what we call nodules. Basically, you can see in this section here, you can see these nodules are basically look like little balls, or you might say little marbles or BBs that you can see in the tissues. Most often, it's in the lower half of the lung more prominently than in the upper half. There's also what we call ground glass opacities. As the name implies, if you think about the sort of the appearance of ground glass, it has that sort of hazy look. So instead of having a dark look like you'd expect on CT scan for a nice open lung, it has this sort of patchy haziness. Consolidation refers to more confluent or sort of connected areas of sort of water density. And then also there's occasionally some fibrosis, some scarring in the interstitium that can be seen in this context. And when you biopsy these nodules in particular, or some of these areas of ground glass opacification, what you see is ultimately really dense sort of infiltration of immune cells. So instead of the nice open lacy lung structure, you see what looks like, and sometimes looks almost like a lymph node in terms of how sort of packed in the cells are. And what are the cells in the lesions? Well, predominantly, or in most patients, the cells in the lesions, as indicated here, are T cells. So T cells stain with CD3. And in fact, most often, the most prevalent cell type found in these lung tissues are actually CD4 T cells. Now, variably, some patients will have a combination of T cells and B cells, but the key thing is that these are not the sort of cells that might respond to, let's say, a pneumonia. If somebody has a pneumonia or they have infection in the airway space, many neutrophils will go into the lung tissue, which is totally different kind of white blood cell than T cells or B cells. Now, how is GLILD managed? Well, in patients that, let's say, have new diagnosis of CVID, it's quite clear that simply optimizing immune globulin replacement therapy can help some of the infiltrations that are seen in the lungs. But really, the issue, I think, for most patients is not this, because they're already on IVIG or some sort of subcutaneous immune globulin replacement. The real issue is the occurrence or the issue, it's sort of the chronic infiltration in the lungs despite being on IVIG and treating infections appropriately. And ultimately, there really is no approved therapy for GLILD, but most patients will receive an initial course of corticosteroids, things like prednisone. And this is the most commonly used agent, and it can help decrease the, infiltrations in the lung. In fact, there's actually a relatively recent report out of Germany demonstrating that that corticosteroids can be effective for treatment of GLILD. The real issue, though, of course, is that corticosteroids are associated with really a host of side effects. And when treatment has to be prolonged, that's really when it becomes problematic. And so it's really not ultimately a desirable treatment for most patients. Now, a variety of immunosuppressive agents have been utilized in second line, and there's really quite a wide variety. I would say probably most commonly these days, people will be treating patients with an antibody that depletes B cells called rituximab, because most patients or most individuals with CVID of course, are on immune globulin replacement. Depleting the B cells, which are the immune globulin producing cells, appears to be a relatively low risk sort of thing to do for most patients. And some individuals with CVID respond well to rituximab, or at least for a year, or at least for a time, perhaps a year or so. There has been some good work performed evaluating the combination of rituximab and an antimetabolite, most often azathioprine or mycophenolate. And this does lead to response in many patients, though not all patients respond. And there is some concern about chronic use of antimetabolites in terms of for long-term health for individuals. So, in our opinion, really, we feel like there's a need for more and better therapeutic options for patients. And so that really leads me to my next point. So why abatacept? Why are we think about this? Why are we thinking about this agent, and why the ABCVILD trial? So first, a bit of background. So abatacept is the brand name of this drug is Orencia, and it is it's a biologic agent. It's a protein that is actually a fusion between part of a protein called CTLA-4 and part of the backbone of human immune globulins. And what this does is it actually binds to molecules, in this case, or specifically CD80 and CD86, that is important for activating and turning on T cells. And so abatacept, ultimately what it does is it sort of dampens activation of T cells. And while I think there's still a lot that is not really fully understood, it turns out that in situations, let's say outside of CVID, that it's actually it's first off here I'll say it's approved for several disorders, most notably rheumatoid arthritis, but also other forms of arthritis. It's also not on the slide. It's also approved for the prevention of graft versus host disease after bone marrow transplantation. So abatacept is actually increasingly used for a variety of different immune disorders, and it turns out it probably is especially effective in terms of interfering with T cells, the T cells that sort of help B cells to make antibodies. And this is valuable in patients where you have undesirable antibodies being made. And just like with rituximab, if somebody's already on IVIG, this is sort of a form of immune suppression that is probably not missed that much in the patient because they're already receiving antibody replacement. Now, in patients with arthritis who are receiving the drug chronically, there is a reported increased incidence of infections. There's not any particular infection. It's actually common, an increased rate of a variety of different common infections. But overall, it does appear to be a relatively safe drug in long-term and chronic settings, and it's been in use now for well over a decade. And so there's increasing experience with this agent. Now, the reason why we originally got interested in abatacept is some years ago, my colleagues and I, we treated a series of patients that were, in fact, very difficult to treat patients that had already been treated repeatedly with prednisone and other medications such as rituximab and antimetabolites like mycophenolate. And they had severe and progressive sort of complications of CVID, including interstitial lung disease, but also infiltration in other organs like the gut and the liver. And what we found, though, that was, I think, most clear and easy for us to measure in terms of their response. They overall responded well, but what we saw is that their interstitial lung disease, their GLILD, really responded quite dramatically, as you can see by both CT scans, but also by functional lung function testing. And so we really have felt that this appears to be an excellent agent for the treatment of GLILD. But over the years, we've been frustrated because this drug is not officially approved for CVID or for GLILD. It's oftentimes has been a challenge to get approval by insurance companies. And so we decided really what we needed to do in order to help bolster our case, but also really to study this and really determine in a more sort of rigorous way, is this drug really as useful as we think it is based on our local experience? We started a study that is called ABCVILD for short, and that stands for abatacept for the treatment of common variable immunodeficiency with interstitial lung disease. And this is my colleague, Dr. Kellner, who's since left Cincinnati Children's, and I developed this study to really to ask this question: is abatacept useful for patients with GLILD? And we wanted to do so in a way that was really unambiguous and very clear in terms of determining how useful it may be. So, for this study, we hypothesized that we'd be able to see a significant improvement, as you can see here on the slide here, in the majority of patients in their CT scans after treatment with either 6 or 12 months of abatacept, and that this would be better than placebo. And I'll show you the design of the study here in 1 second. And the primary objective of the study was to follow patients being treated with abatacept in a blinded fashion, meaning we don't know whether the patient, neither us nor the patient knows whether they're receiving the drug or a placebo initially, to see if how this affects GLILD in terms of their radiographic imaging by CT scan, but also other parameters in terms of blood testing and quality of life and so forth. And so we have a specific scoring system which we're utilizing in collaboration with our radiologists here. And let's see here. The other objectives of the study, as I sort of just alluded to, is we're going to look at the pulmonary function studies to see how those are affected in this patient population. We also want to assess if patients have other inflammatory features. Are those features also are they affected by treatment with abatacept? We want to compare in a small number of patients, they'll receive a longer treatment versus the majority of patients. And I'll explain that in 1 second with probably the next slide. Since we know that many patients are sort of chronically off and on corticosteroids like prednisone, we want to understand if how treatment with abatacept affects concurrent treatment, such as corticosteroids, to see if patients can actually come off of these medications. And for a limited number of patients, we will do some experimental imaging to also assess the impact of the drug on GLILD. I'll explain that more in a moment. And we also want to monitor closely for infectious complications that the patients may experience. And overall, we want to assess how safe is this approach and how tolerable is it in this patient population. And then finally, we want to look at how it affects quality of life for these patients. Now, inclusion in the study is really a standard diagnosis of CVID, which is listed here, which this is sort of maybe more details than maybe people want, but suffice it to say, if somebody has a clear diagnosis of CVID and they've already been on immune globulin replacement, either IVIG or subcutaneous, for at least 6 months, meaning that they're truly on stable treatment in this regard, and this is not sort of a new diagnosis. And of course, if they have a diagnosis of GLILD, and this is diagnosed by lung biopsy, and that the patient has had a persistence or worsening of the interstitial lung disease for at least 6 months. And this is important. And part of the reason we designed the trial we did is that we know that GLILD can sort of get better and worse over time, usually not going away, but sort of, you might say, sort of fluctuating. So we want to try to understand how is the disease persistent despite being on sort of stable immune globulin replacement. And of course, patients have to consent. And we are gathering biologic specimens, importantly, for really trying to better understand how abatacept may work. And because of unknowns regarding treatment of pregnant women, I think this is also important that really we have to be cautious in terms of what's known about the use of abatacept. And then exclusion criteria, just briefly, if somebody is known to react to or have any sort of hypersensitivity to abatacept, that would be an exclusion criteria. Or of course, if somebody is currently on the drug, there are certain recent therapies. Just for simplicity's sake, I'm not going to spell them all out here, that might affect temporarily, significantly the GLILD. So again, we wanted to make sure patients are on relatively stable, regimen. And many therapies that patients are on chronically are allowable to be continued while on the trial, but there are just certain ones that are more problematic than others. So we can obviously speak to individuals that are have specific questions about this as needed. Also, there are certain infections that we want to be more cautious about, and so if they're uncontrolled, we would exclude patients from joining the trial. Likewise, recent malignancy is a confounder, and then of course, as I already kind of alluded to, pregnancy or breastfeeding, because the abatacept is not approved in that context at this time. Now, the design of the trial, and this is a little bit busy, but we're hoping to enroll approximately 30 patients onto the trial, and both adults and children. Now, the pediatric arm is simple. For practical reasons, we really only will be dosing with abatacept. In other words, we won't be testing the drug in a blinded fashion. But the adult arm, the way the study works is that patients are on the study for 1 year. The first 6 months, it's a blinded phase, meaning we don't know who is on placebo and who is on active drug. But we will monitor both groups equally, and there's a brief course of prednisone to sort of start the treatment period if somebody's not already on prednisone. And we will monitor blood inflammatory markers, and I'll explain that more about that in just a moment. And that may lead us to adjust the dose of abatacept, because one of the unknowns in this context is whether or not patients with CVID may need more of this medication than patients with, for instance, rheumatoid arthritis. But at the end of 6 months, then there'll be sort of a global reassessment of the GLILD in terms of how it has changed over those 6 months. And then for the next 6 months, all patients will receive abatacept in what we call open label, meaning it's not blinded, there's no placebo, and so the treatment will continue for another 6 months. So as you can see, the patients that get the blinded abatacept at the beginning will actually have a full year of abatacept. The patients that receive placebo initially will still receive abatacept for the second half of the year, so they'll receive 6 months of treatment. We think that 6 months is actually sufficient, really, for sort of the maximal response to this medication. And so the study lasts for a year. Now, we also have a commitment from BMS that if patients have benefited from the medication and they would like to stay on the medication after the study is completed, that they have sort of a extended access program in which we can continue to receive the medication free of charge from the company for the patients that would like to remain on treatment for up to 3 years after completion of the study. So, so that's the overall design. Now, along with this study, we're doing, along with this treatment aspect of the study, I should say, we're doing some additional scientific studies, what we call sort of mechanistic studies, to try to understand the mechanism of what we have observed previously in clinical practice in terms of how abatacept may be working. So one of the questions I sort of alluded to is we don't know if patients with CVID will necessarily need more abatacept than the standard. We also, and part of the reason we don't know this is sometimes individuals that have inflammatory complications such as GLILD will have inflammation in multiple parts of their body, including in the gut. And there's a reason to believe that if the gut is involved, then abatacept may be cleared more quickly from the body. And so we're going to measure levels of this medication in patients and see how this correlates with their response and ultimately with their outcomes. And one of the things that we have noticed historically and we previously published is that one sort of inflammatory marker or one marker of immune activation called SCD25, that stands for soluble CD25, if this is useful for what we call adaptive dosing. And what we have, and actually I'll show you a slide in just a second. And then additionally, we will look at details at immune cells circulating in the patients to see how they are affected by abatacept. And then finally, we will look at sort of in a more global way how abatacept affects a variety of aspects of inflammation by looking at what we call the blood proteomics, which is a very broad measurement of many, many different pathways of inflammation to better understand exactly how this medication affects the inflammatory process that is still very poorly understood in patients with CVID. Now, I mentioned SCD25 as a marker of immune response to abatacept, and this is some previously published data. So we know that patients with inflammatory complications of CVID often have an elevation in this marker. And now, this marker is a really interesting one in that it comes from predominantly, we think, from activated T cells. And it's actually a marker that's on the T cell itself. When the T cell becomes activated, it actually cleaves off this protein and it circulates in the blood, and that's where we can measure it. But what we noticed in patients that with CVID that were receiving abatacept that had responded well to this treatment, that in all cases, the soluble or the SCD25 actually fell quite dramatically when we treated them with abatacept. So we are utilizing this marker as a way to help us adjust the dosing if needed in patients. We think this is really the first time this has been done in a trial. Now, other groups, including Klaus Varnitz's group, has noticed as well in patients with CVID that when they're treated with abatacept, that SCD25 is also a really nice marker to follow, that it comes down quite consistently, and it correlates with decreases in sort of harmful or inappropriate inflammation. And then finally, one of the sort of other exploratory aspects of this study is that a small number, not all the patients in the study, but a small fraction of the patients on the study, we will offer this sort of experimental sort of imaging modality called xenon MRI. Now, xenon MRI actually technically is actually FDA approved for other disorders. It's not widely utilized in the US. It's only really available at a few centers. But we hope to examine the impact via xenon MRI for patients receiving abatacept. And the reason why is this is a radiation-free way to image the lungs, and it tells us a tremendous amount about how the lungs look, just like we see with CT scan, but also how the lungs function in a way that's actually kind of unique and complements standard sort of pulmonary function studies. And so this is, like I said, one of these sort of mechanistic studies that's a part of our overall study. Now, the trial is currently open here at Cincinnati Children's Hospital. It's also open at these 5 other centers you see listed here. We plan to, we have essentially enrolled about half of the patients we anticipate enrolling on the study, and we plan to complete our enrollment over the next couple of years. And so we are always looking for new patients that may be interested in participating in the study. And so, in conclusions, I think it's still unfortunately true to say that GLILD in patients with CVID really does remain a significant challenge. This is a chronic condition where that's still really quite poorly understood. Like as I mentioned already, there's a variety of different drugs that have been used. And it does respond to a variety of different treatments. The problem with many of them oftentimes is that response is variable, or it may the medications may have significant side effects. that really require one to stop treatment, and the issue comes right back. So this is, I think, still one, and clearly, I think that we need new agents to give us more options, and particularly, we need agents that are well tolerated and safe long term, and if abatacept proves to be as effective as we suspect it may be, I think it certainly would fit that description. And so I think that, as I already mentioned, that I think there's real potential here. Again, it's thus far is not a standard approach. It's not something that is what we call on label, but I think that there's potential. And the ABCVILD trial is really testing the potential of this approach. And so I think we hopefully we will learn with the most rigorous way possible with a placebo, sort of a blinded placebo control sort of strategy, the true utility of this agent. So thank you very much for your attention, and I can take questions now.
All right, thank you so much, Dr. Jordan. That was a great talk, and we have some great questions lined up from our audience. So, again, we have a little bit of time set aside here for Q&A. So, if folks would like to ask questions, we invite you to add those in the Q&A box. We have a couple of good ones to get things started. So, just want to remind everybody we have some ground rules which have just been shared in the chat. So, we ask that you please mind those as we go through the Q&A portion of tonight's talk. All right, first question. This first individual says, great lecture. I agree. To clarify, how do you determine when a CVID patient has progressed to GLILD versus other lung complications? I know you talked about just regular interstitial lung disease. You mentioned bronchiectasis. How do you kind of know what is going on in terms of progression with the lung complications? Obviously, we know that you can use radiology for diagnosis, but what are other symptoms that a patient might experience?
Yeah. So, yeah, distinguishing GLILD from other lung complications is already, as you mentioned already, is significantly based on imaging, right? So things like bronchiectasis have a different appearance than GLILD does, but imaging can be like CT scans. It can still be a bit ambiguous. So, some things, like I said, are easy to recognize as something different, like bronchiectasis or, for instance, pneumonia. But sometimes it does require sort of empiric treatment with antibiotics and repeated imaging to sort of assess sort of the trajectory of the GLILD. And I think that's probably um, the the simplest answer. In terms of how patients feel, GLILD is a problem that definitely contributes to and causes declining lung function. It's not always something that people necessarily can feel it's something that you can see on a CT scan, but it may not be readily apparent to somebody until it's really very long standing and has sort of continued to progress. So, symptoms do not always correlate perfectly with what could be measured, by getting a CT scan. And sometimes as the CT scan, you can be uncertain exactly what you're looking at, and so biopsies are really important. Not necessarily repeated biopsies, but at least an initial biopsy to understand, is this sort of appearance on the CT scan? Is it really is it explained by CVID? And a biopsy would sort of unequivocally answer that sort of that question.
Thank you so much. All right, next question. Can you provide some additional clarity on what the patient journey looks like through this clinical trial? I know we talked about there's 5 different sites. It's open to pediatric and adult patients.
Hmm.
As far as what's kind of the start to finish process from enrollment through treatment and monitoring,
Hmm.
and what should patients expect in terms of frequency of visits, check-ins, that type of thing?
Yes. Yeah. Thank you. That's actually an excellent point. I'm glad you gave me the opportunity here to explain this. So the trial itself for a participant, somebody would participate in the trial for a year. And as I mentioned, there's the possibility of extended treatment if the individual and the treating physician agree that that would be a good idea or they want to do so. But the trial itself lasts for a year, and so in order to enroll in the trial, there needs to be some blood testing to confirm that somebody meets all the eligibility criteria. So for instance, if somebody, let's say somebody has a diagnosis, who they know they have a diagnosis of CVID, they know they have GLILD. This is something that's been known for a while. They already have, CT scans to demonstrate this, and they've already had a lung biopsy to determine, what exactly is the lung process. Then in order to participate in the trial, they would obviously need to sign a consent where the investigator would go over the trial in detail with the individual to see if they, are agreeable to it. But after signing a consent, then there would be a blood draw to see if they meet all of the eligibility criteria, and if that is the case, then the patient would have their initial visit where they would receive sort of the blinded medication that's either placebo or the drug itself. And then over the course of the year, the patient would come in every 3 months to receive more of the medication. So there'd be an initial visit, and then 3 months later, 6 months later, 9 months, and then 12 months later. So there's those visits. And then in between these visits that are every 3 months, there's a phone call once a month just to sort of go over if there's any symptoms or anybody's experiencing any difficulties. So in the end, it is basically these four visits, one every 3 months over the course of a year, and in between on those off months, a phone call, and also there's a blood draw once a month. So timed around the time of that phone call would be an additional blood draw. And there are some surveys that we'd ask people to fill out as well in terms of about their quality of life and how how they're doing and how their participation in the study has affected them. And that's really I think sums it up. So it's sort of four visits. There is a baseline scan that doesn't that the patient may already, if they've had a recent scan that's suitable as a baseline. There'll be another CT scan at the 6 month mark, so after this blinded phase, and then another scan at the end of the study. So they're basically, if somebody already has a recent CT scan that would count, they wouldn't need to get another one, but they would get two more CT scans over the course of the year. So that pretty much, I think, sums up the experience. And so for patients, we have patients that are from coming a long distance in many cases to the treating center. That would mean that they would go to the center essentially 4 times because everything else could be done, things like blood draws and so forth, and phone calls, of course, could be done from a distance.
Sure. Thank you so much. That was great information. All right, next question. So I know you talked a little bit about patients already on immunoglobulin replacement therapy. Can you go back to that portion, just revisit that part of your talk, and share about how that kind of fits in with the abatacept integration? So they're safe to be on both treatments at the same time. Can you share, are there any sort of complications that can arise or any sort of things to consider before you would dive into the abatacept if you're already on IVIG or sub-Q?
Yeah. Yeah. No, there's no interaction between abatacept and immune globulin replacement. And in fact, honestly, there's really no interaction between abatacept and essentially any other drug, right? And the reason we don't permit certain treatments is not because of an interaction, because one of the things that we for the trial we say is that you couldn't have had just had a recent treatment with rituximab, only because it makes it very hard for us to assess whether or not what we're measuring is the recent rituximab versus the effect of the abatacept. But it's not that there's a worry about drug interaction between the abatacept and essentially any other treatment that somebody would be on. And there's definitely no interaction between immune globulin and abatacept. And we specify that somebody has to be on immune globulin for at least 6 months, only because sometimes when patients are first, diagnosed with CVID, they may already have GLILD, and just getting on immune globulin can actually make things sometimes significantly better. Not necessarily make it go away, but now you don't have sort of a stable baseline to compare this new sort of treatment to. So it's really just for kind of practical, you might say almost sort of study related scientific reasons that we have these sorts of restrictions, not because there's a worry about combining abatacept with immune globulin replacement or a variety of other medicines that the patient may be on stably.
Sure, thank you so much. All right, next question. Are there any specific biomarkers or sort of patient characteristics that might help predict if someone is going to respond better or poorly to the
Hmm.
abatacept therapy? I know you had that pharmacokinetic slides earlier. This person
Hmm.
said they got a little lost on that part, so if you could just refresh
Okay.
us all on that section.
Yeah. So, well, first, the shorter answer is we don't know. We hypothesize that the patients that have a high SC20, CD25 will probably be the ones that are most likely to benefit from abatacept. And the reason, I can sort of explain why I hypothesize, but I should start with the bottom line is that there aren't any markers that we know of right now that will predict this. In fact, this is one of the things we're really trying to understand with this study is will we determine whether these markers are predictive, right? But we know that abatacept sort of calms down certain aspects of T cell activation. And we think, and we know that soluble CD25 or the SCD25 comes from activated T cells. For hitting this really precise sort of targeted way, then there should be sort of a nice correlation between somebody that has a lot of this SCD25 circulating and their sort of their, you might say, their need for something like abatacept in essence.
Thank you so much. All right, so talking about abatacept, we have some people who are wondering about the broader implications and other, uses for this treatment. Are there other non-infectious complications of CVID where abatacept is a applicable treatment option?
Um, so, so we previously described that patients have had improvement in other issues. And so, not, I would say, not as part of a scientific study, but as part of medical practice, I've definitely seen improvement in things like improvement in autoantibodies, like that drive things like ITP or autoimmune hemolytic anemia. We've seen improvement in gut inflammation, I'm not aware of a specific. So we haven't been able to document improvement in liver inflammation, in part because we don't often want to just keep biopsying livers, right? If somebody doesn't have a critical need for that, so it's difficult to measure. And I'm not aware of anything that anyone else has published regarding that. But we think that it actually probably is likely to be beneficial for a variety of different sort of complications that patients with CVID experience with sort of these inflammatory complications. We chose the interstitial lung disease for a couple of reasons. One is that our perception, again, this is not proof, our perception is that the lung disease is maybe more responsive than gut disease. But the main reason we chose lung disease is that it's more measurable than many of these other sort of conditions. So it's oftentimes it's unclear how best to measure things like gut inflammation, right? And as I already alluded to, if somebody has liver inflammation, we're not doing repeated liver biopsies. There's no real good reason to do that for most patients. So there's virtually no way to measure how it may have benefited or not, let's say somebody's liver inflammation. But we can measure lung inflammation either by functional studies or by CT scans. And so that's really kind of why we chose it for sort of pragmatic reasons. But we think that and of course we can measure blood tests, right? But yeah, but we think it's likely to benefit other aspects. But again, we kind of have to focus on one thing in any sort of clinical trial like this. And so we're focusing on the lung disease primarily.
Thank you so much. You also mentioned, so we know that there's 5 sites kind of scattered all over the country, and that you have a lot of people who travel in for these, quarterly check-ins and such at their participating center. I'm wondering, is there any sort of financial or travel support for the folks who are having to, whether it's fly in or drive, 4 hours or whatever, to get to their participating center? Are there any travel assistance or anything available?
Hmm. Yeah. Um, we um, uh, We it can vary by center, I should say, but for the most part, it's very limited, and I think that's probably the best way to sum it up. I would encourage you to reach out to the center that might be closest to you to discuss.
Thank you. All right. So this is kind of just a general question about, participating in clinical trials. I think it's an interesting question given that, this particular trial is for both adults and children. So, for someone who's watching tonight who might be on the fence about maybe it's about how, participating themselves or having their child participate, what would you say are some of the most sort of common hesitations that you hear from patients and families, and how do you work to kind of address those?
Hmm. Yeah. The So focusing on interstitial lung disease. So as I mentioned, sometimes patients they may find out they have a diagnosis of CVID because they have an infection, for instance, right? And they get on IVIG or subcutaneous immune globulin, and they're feeling better. They're not having infections, but their physician, notices that they may have other immune issues, whether it might be immune-mediated cytopenias or some other symptoms. And so, as part of working things up, they identify that they have interstitial lung disease. But oftentimes the patient, may not necessarily feel like they have a lung problem, and they may not feel for years, right, they have a lung problem. So the question sometimes comes up is, well, I understand that, by testing, I have this sort of inflammation in my body, but maybe I'm not really bothered by it that much. I mean, some patients certainly are, and maybe it won't bother me for some years. Should I receive treatment now? And I think that's very much an individual situation. It's difficult, for me to give a real blanket sort of answer to that. But I think that's kind of the sort of question I think where patients may say, yes, I've had some issues, but I feel like I'm doing okay. I don't know that I necessarily want to take another medication, right? And I would point out that I think to be fair, I think that this medication is an attractive option because it appears to be so well tolerated, but no medication is ultimately perfectly safe. And what we're talking about here are medicines that are different forms of either anti-inflammatory that one might utilize or immunosuppressive in various ways. And abatacept is an immunosuppressive medication. It's very targeted, and it's one that appears to be, and one that appears to be sort of the kind of medicine that one could take chronically for a very long period of time. Unlike some medicines, it's just not really, feasible. But nothing is risk-free. And so I think that for anyone, thinking about this, I think that I would say that, yeah, the important thing is to kind of balance the potential risk with the potential benefit in terms of trying to decide what's best for you. And like I said, since sometimes GLILD is something that we can see very clearly on a CT scan and on a biopsy, the patient may or may not feel that bad. And so they may say, maybe I'll think about it next year or the year after, right? And I can't argue with that if that's the way the patient judges is best for them. But that's sort of the main issues that I see. And in terms of how I advise people, if somebody has significant involvement, especially if they're relatively young, then I would anticipate that it's likely to only continue or worsen. So I would consider, whether or not, getting on treatment would be the better choice for them in terms of preventing future problems that may not be so evident right now, but might be really significant in the long run.
Sure, thank you. That was a great answer. I know that's kind of a hard kind of blanket statement to make, so thank you for tackling that question. Kind of in that same vein, asking about considerations before you apply to be a part of a clinical trial or you kind of approach that. Um, do you have any sort of overarching categories of, maybe what rules you out or what would make you not an eligible participant to be a part of this study?
Um, so, um, I've listed a sort of a paraphrase of sort of the exclusion criteria. I think that's what you're referring to, right? So obviously we're talking about inclusion, somebody with CVID who has GLILD, who's on a sort of stable treatment, right? Is sort of the simple, sort of characterization of who is eligible, who would be sort of excluded from participating, as I mentioned, is if somebody's pregnant or breastfeeding currently, is one of those that's sort of, per the FDA, we're not allowed to enroll people because we don't understand. Nobody really knows how it may affect the child. The other issues if somebody's had a big change in their therapy recently, like they just received, say, rituximab, then they wouldn't be eligible for a while. We actually say that if somebody has a new baseline more than 6 months after rituximab, that would be okay. For instance, I didn't want to get into all the details because it does vary a little bit by the different specifics. But one of the things that's listed there is, I think, if somebody's ever had a reaction to abatacept. As far as I know, I've never ever heard of anyone ever having a reaction, so that's probably not going to exclude anybody. But for the most part, it's if the patient, has the diagnosis and is stable, and does not have any ongoing issues with a couple of viruses we wanted to be careful about, and one is hepatitis B, and the other one is EBV. So if they don't have any ongoing issues, significant issues with those viruses, then and HIV as well, excuse me, then generally speaking, most patients would be eligible.
Thank you. All right. Moving on from kind of the ins and outs of the clinical trial, we have a lot of questions now that are kind of abatacept specific, so I'm going to get into those.
Mhm.
So this person says, first of all, thank you for the talk. So is the vision for this study that patients with GLILD who respond well to the abatacept would be on this for life, assuming that the FDA eventually approves this as a GLILD treatment?
hmm Yes. So um, the assumption is that if somebody is benefiting from abatacept, that they should stay on it. And I say assumption because we don't really know if taking a break is necessarily going to cause a problem. In clinical practice, I've had patients for one reason or another have to come off, not because they have trouble with it, but because of insurance or things like that. And the benefit does seem to sort of fade away if somebody's not taking it. It's not necessarily an immediate sort of snapback, but so for its benefit, it does seem that it needs to be sort of a sustained therapy.
Thank you. All right, next question. So this individual shares, it's suspected that I have GLILD. They had some scans recently done, but they're not currently having issues or symptoms. Given that fact, does it make sense to treat?
Hmm. Right. Again, this is sort of it is probably there's I would say discuss with your physician really to have the best sense. But in general, I would say that if somebody's not symptomatic and their scan does not look very severe and they don't have any other sort of features that are immune problems, right? These sort of inflammatory features that are causing problem for them, then I would say that yet not treating is a very reasonable approach. Now, if the treatment is something that has a lot of side effects, then it's even smarter to not treat, right? In other words, why take a medicine with side effects if you don't have any perceived problems? But I think the caveats around not treating are is I would make sure that that there is that for instance, the scans are not really very severe appearing, and because maybe there's more going on than somebody might perceive if they don't, everybody's sense of their own body varies, and so I'd sort of calibrate this sort of lack of symptoms to what does what does the immune testing and the imaging sort of indicate in the sort of the functional studies. But if they're all kind of consistent with each other, that the imaging doesn't show anything that looks severe, the functional testing doesn't show anything that looks severe, and the patient doesn't feel any issues. And they're active and that sort of thing that where they might be able to feel an issue if they had one, and they don't have any other related sort of inflammatory features that's a problem, then that may be very reasonable to simply monitor. I think that there are some issues that you would could view as like this is a problem for me right now, and there are other issues that say, well, this could be a problem for me in 10 or 20 years. So I think about like managing cholesterol, right? We're all probably pretty bad about cholesterol until we hit our 40s and 50s, most of us, right? And then we think, oh, I better get on this. But if you don't think about cholesterol until you're 75, that may be a little late, right? So this is not the same as cholesterol exactly, and I think but it is important to think about sort of timescales, like when is this likely to become an issue, and if there's something that is potentially a problem, then probably the best thing to do, if not treating, is to make sure still keep an eye on it in terms of, is it becoming more of an issue?
Thank you. All right, next question. This person just wanted to clarify about uh, what is abatacept? So they said that
Hmm.
they thought it said on one slide that it was a weekly infusion, and then they thought they said on another slide that it was a shot or a pill. So can you clarify what is the method of administration for the abatacept and what that process looks like?
Hmm. Yeah, so abatacept actually comes in two forms. So one is an IV infusion that would be given typically monthly. And the other form is sort of a preloaded syringe that is somebody would inject themselves with at home weekly. So it's kind of like, immune globulin replacement. You can get an IV version that you would get typically monthly, or you could do subcutaneous things like Hizentra that you would give weekly, right? And so it's the same medicine in both forms. Now, for the purposes of the study, we're utilizing the injected form that's injected once a week under the skin. And it's a small volume. It's not like Hizentra. It's not like the large volume that has to be infused. It's really just a simple injection. It comes in preloaded in a syringe. And in terms of, what is abatacept? So it is a protein It's actually technically it's a recombinant protein. It takes the part of one molecule called CTLA-4 and it puts it on the backbone of human immune globulin. And so it's what we call an FC fusion protein. There's a number of these medicines for different things that basically combine, mix and match different parts of different proteins with antibody molecules. And that backbone is just a carrier, but the active part is the CTLA-4. And so it's a protein and it's sort of handled like IVIG, right? You wouldn't want to let it dry out. It's gonna destroy it if it dries out. So that's why it has to be given. You can't take it as a pill. So that's why you have to take it as either an IV infusion or an injection. Most people, I think, in the world these days use it as an injection strictly for the convenience. But like I said, it comes in both forms. And for the study, for practical reasons, we decided that we would utilize the weekly injected abatacept.
Thank you so much for clarifying. All right, next question. This individual shares, I was diagnosed a few years ago with a development recently of bronchiectasis. I am going to be evaluated for possible lung transplant in about 3 weeks. From your perspective, is there a chance that abatacept in this trial could lead to another avenue other than transplant? Or for GLILD, I understand you can't speak to my exact situation, just interested in your thoughts.
Yeah. So we don't think that abatacept is likely to be helpful for bronchiectasis. So the process in probably most patients with bronchiectasis is there is due to infection in the airway, there's injury to the airway itself, and that causes some scarring and distortion, and that's what we call bronchiectasis. And that's different than the interstitial lung disease, where what you have is you have immune cells in the tissue spaces that are supposed to be real thin and paper thin in the lungs, right? So it's like a big, like a sponge, right? But the sponge itself is getting thicker and thicker, with cells, and so if somebody is their principal concern is bronchiectasis, then I would say that they may or may not be. If they also have interstitial disease, they could be eligible for the study, but I wouldn't expect this sort of treatment to be beneficial for bronchiectasis. Now, if somebody is, being evaluated for lung transplant, then there's probably significant sort of what we call kind of structural, maybe permanent injury to the lung, in terms of the structure of the lung that may not that no medical therapy may help improve that. But specifically, bronchiectasis is one that we don't think that abatacept is really kind of relevant for.
Thank you so much. All right. Winding down on questions, is there a website or an email address I can reach out to share that I'm interested in participating or kind of initiate that enrollment process for this study?
hmm Yes, and I realized I didn't put that in my slide deck. Emma, is there a way that we could post this
Yeah, if you
on
send
the?
it to me, we can
Uh-huh.
post that information when we upload the video to our website and YouTube channel.
Yeah, and the flyer I have is for it lists the Cincinnati contact information, but I realize that you may be closer to another center and may want to prefer to go to one of the other centers. If you reach out to us, we can connect you with wherever you would want to go if you don't want to necessarily come here.
Sure. And could they also find more information by visiting clinicaltrials.gov as well?
Of course,
Okay,
yes, yes,
awesome.
that's always an option, though it's not always unless you're used to it. It's not
Yeah,
necessarily
it can be
the
kind of a
most
lot
user
to
friendly.
navigate, but yeah. All right, well, we'll
Yes.
definitely include that information when we post the video and everything. So thank you so
hmm
much.
Yeah.
All right, well, that is going to wind down our questions. I did get a nice comment though. I kind of wanted to share before we move on. This person just anonymously shared they've been on abatacept for over a decade and it has saved their life. They just wanted to share their positive experience. So
hmm
thought that'd be a nice one to close out with. So with that, I think we're going to wrap up our Q&A and work towards closing out the webinar for this evening. But I just want to thank everyone in our audience for your very thoughtful questions. And thank you so much, Dr. Jordan, for the time time that you took answering these thoughtful questions and for all of your efforts putting together this wonderful presentation. Thank you so much.
All right. Thank you very much.
All right, and with that, we are going to move on to talk about some resources and upcoming events, and then we will close this thing out here in just a few moments. So thank you so much, everybody. All right, primaryimmune.org is your go-to website for additional resources, upcoming events, and more. All materials are free to access, print, or have mailed directly to your home. And if we didn't get to your question during the program, you can contact our board-certified patient navigator through Ask IDF. She is amazing. She will personally connect with you to tackle your question and direct you to appropriate resources. You can even take IDF on the road with our engaging podcast series. You can find programs like Bold Conversations, Undiagnosed, and Chronic 20s by searching for the IDF podcast. We also have a YouTube channel you heard us just mention, where you can find recordings of all of our digital education events, including tonight's program, and that will be posted both on the YouTube channel and the IDF website here in the next couple of weeks. Find a safe and supportive environment to link up with others impacted by PI through our Get Connected groups. These groups are free, virtual, volunteer-led opportunities to connect with others with PI all over the U.S. We offer location-based groups, so in your city or state, diagnosis-specific groups, and nationwide groups. And because we meet virtually, you can join any group that works for you. Check out the IDF calendar of events to find a group that might interest you. We also offer facilitated support groups for young adults, parents and spouses, and partners, as well as a peer support program if you're looking for something more one-on-one. Walk for PI continues through the end of the year with events coming up in San Antonio and coast to coast. It's not too late to start a walk team and become a part of the movement. Just visit walkforpi.org to get started. And here at IDF, we're so proud to offer educational programming each month and various in-person events throughout the calendar year. We hope to see you back for our last couple of education events, as well as our second annual Winter Soiree, as we celebrate our incredible volunteers and all they have helped us to accomplish in 2025. And speaking of upcoming events, it's never too early to start thinking about Advocacy Day 2026. That's coming up next spring. This event is by application only and it will fill up fast. Visit the link in the chat to apply today. And finally, we hope you'll save the date for our 2026 National Conference taking place next June in San Antonio, Texas. Visit primaryimmune.org/conference to be notified when registration becomes available. And we are so excited to announce that IDF is part of Walmart's Spark Good Roundup campaign, where customers can round up their purchases to the nearest dollar and donate the change to their favorite charity. So all you have to do is visit walmart.com/sparkgood, search for the Immune Deficiency Foundation to set that as your charity of choice, and then sign into your Walmart account. And from there, you can donate spare change by automatically rounding up your orders to the nearest dollar at checkout. All right, to our audience members, thank you so much again for joining us tonight. We're now going to launch our final poll of the evening. So again, we'll give everyone about 30 seconds to answer. And our closing question is, after tonight's program, how would you rank your understanding of how primary immunodeficiency relates to granulomatous lymphocytic interstitial lung disease? All right, thank you everybody for your feedback. All right. And with that, we're going to be trying something new. And we're going to go ahead. I'm going to turn on the chat so everyone is free to go ahead and chat. And we're going to ask you to share one new thing that you learned from tonight's program. So go ahead if you'd like to share. You can go ahead and put that in the webinar chat. Again, we just ask that you respect the same rules as the Q&A. We'll give everyone a few moments to add in their thoughts, and then we'll see if we have a couple of good ones we can read out loud. All right, awesome. Thank you guys, and thanks for working around with me with the chat. Have some good comments here in the Q&A. A lovely note from one individual. Thank you for your lovely note. Another person shared that they learned that GLILD is related to T cells. And another person shared that they finally understand what GLILD is, which is great, which is why we're all here tonight. So thank you, everyone. Oh, some more people. This person shared that they learned that 30% of people who have CVID end up with GLILD. I certainly didn't know that. And then some other people commenting that they learned about the new types of MRI that can see lung function. Very cool. Um, and Oh, I love this. This person shared they learned that watchful waiting is a reasonable response. I love that. This person is pleased to know that abatacept will not interfere with their IVIG. That was also great to hear. And another good one, this person learned that they learned to distinguish the difference between granulomas and bronchiectasis. So very cool. All right, thank you everybody. That was cool to hear what everyone's individual takeaways were, and I'm glad that this was helpful and people learned a lot from tonight's program. So thank you so much. All right. Before we go, I want to give a heartfelt thank you to our amazing volunteers and supporters who make programs like this possible. If tonight's presentation resonated with you, we hope you'll consider supporting future IDF programming. Your donation at any level helps us continue building community and delivering meaningful content like tonight's program. Thank you so much for being here. All right, with that, Dr. Jordan, I think he's left for the evening, but we want to thank him again for leading this important discussion and sharing his time. Oh, sorry, you're still on here. Hi, Dr.
I'm
Jordan.
listening. Yes, thank
I will
you.
thank you. I will thank you so much for leading this important discussion and sharing your time and expertise with our community. I think you could hear just now, people had a lot of great takeaways and a lot of insight gained from attending this. So thank you so much. And thank you to our community for joining us and for making these programs possible.